one on implantable cardiac devices and LVADs, one on hospice and palliative care, including a guest from Moffitt Cancer Center in Florida, and one on colon cancer and lung cancer. And then we, like I mentioned, we do have our corresponding behavioral science and healthcare seminar series that you're also welcome to attend. And that brings a social ecological model, multi-level model approach to understanding behavior change at the individual, practice provider, organization, community, and policy level. So we do have those upcoming as well. Some of those are still sort of to be determined and not yet confirmed. So go ahead and switch over to Laura. Okay, and Brian's going to do something. Or do you want to use this microphone or this? Yeah, I'll use this mic.
I'll just use this one.
Okay. Yeah. And we learned yesterday that the dry erase markers do not work.
It's okay, I won't be using them anyways. I have terrible handwriting and be useless for everyone. So, okay. Yeah, okay, great. It's good to see everybody here, and I want to say that I changed the title of this slightly to A Brief Introduction to the Psychology of Shared Decision Making, because as I was developing this talk, I realized that I have about a year's worth of information that I could give to you. I could teach a year-long course on this, in other words, and boiling down what I wanted to say into an hour was virtually impossible. So really, this is just a brief introduction to the sorts of issues that are the sorts of psychological phenomena that are relevant to shared decision making. It was also kind of difficult because a lot of stuff I like to talk about is about emotion and affect in decision making. I will be talking about some of that today. We have, though, an amazing world expert on this, Gretchen Chapman, coming next month. And if you guys are at all interested in what I have to say here today, you absolutely must go to her talk next month because she is phenomenal. Okay, so that said, I will just get right to it and tell you what it is that I have to say for today. So the first thing I wanted to do with this talk is just make sure we're all on the same page with regard to thinking about shared decision making. And I'm going to do this really briefly because I know many of you are already familiar with what shared decision making is. But in medicine, there are a couple of different forms of shared decision making, or generalities. The first is this paternalistic mode that we're all very familiar with. A physician analyzes a situation and tells the patient what to do and what's going to happen. Informed medical decision-making takes this one step further and informs the patient, gives the patient really good information about the risks and the benefits of the test or treatment that is being considered. And then shared decision-making is used in contexts where the clinical evidence suggests equipoise, and that this decision is preference sensitive in the sense that maybe the benefits of the test and treatment don't clearly outweigh the potential risks, and the right course of action depends on the patient's risk tolerance, their personal preferences, and their values. Okay. So shared decision-making at its most fundamental level requires that patients are informed, and that will require that someone somewhere along the line communicates the risks and the benefits of the test or the treatment that's being considered. And that is sort of what I'm going to focus on today, is how do we communicate that, and how then do people understand the risks and the benefits. Shared decision-making also requires things like an activated patient who understands that there's a decision to be made and that it depends on their personal preferences. But the overarching goal of shared decision-making is to have patients who are making decisions that are informed and that they understand the risks and the benefits, and they're also incorporating their personal preferences and values into this decision. Last bit of background, and if you were at the last talk with Chris and Dan, you would have gotten a lot of information about decision aids. So decision aids can help us to present information about risks and benefits to patients. It can help us to inform them optimally. It can help them become aware that there's a decision to be made. And decision aids are very valuable in that respect. In fact, some people argue that they can really streamline the communication between the physician and the patient insofar as it takes away a lot of the burden for conveying complex information to patients. And then patient decision aid goals. All decision aids are meant to improve the patient's knowledge, help them develop accurate risk perceptions, and that is difficult, and you'll see why in a minute. Make patients aware there's a choice, help them feel prepared, and also help them to understand what their values are and how that maps onto the decisions. to the decision options. Okay, I give you all that background for those of you who might not be intimately familiar with this stuff, but also because it provides a little bit of a framework for understanding all the various ways in which basic psychological phenomena can be relevant to shared decision making. So at the most basic level, you have just information encoding and recall on the part of patients, and how does that work? On a secondary level, you have risk perception, cognitive and affective biases that are relevant to people's risk perceptions, their abilities and competencies that allow them to understand risk, like numeracy and also literacy. You have mental models of disease, patients' attitude and trust of the healthcare system, trust in their physician. People make different decisions for themselves versus other people, and there are also cultural and social issues at play, like stereotyping and prejudice, that may impede the communication between the physician and the patient. So there's like all these psychological issues, and you can see why this is such a big thing to grapple with. So today I'm just going to cover this stuff. One small piece, but it's been a very important piece of understanding the psychology of shared decision. Okay, so without further ado, risk perception. I just want to reiterate, because this is such an important point, that patients have to evaluate risks and benefits of treatments. And so I want you to just consider something, or a few different somethings actually. How should a patient evaluate a 25% chance of a heart attack in the next 10 years? Or a 15% lifetime chance of developing breast cancer? Or a 5% rate of complications following surgery? And when I say how should a person understand that, what I mean is, so you tell me that there's a 5% rate of complications following this surgery. Is that good or is that bad? Is that better than the other guy or is it worse than the other guy? Should I be scared? Should I be relieved? What kind of complications are we talking about? Are we talking about the kind that will kill me? Are we talking about the kind that will disable me? Are we talking about something that's just going to require a bandage? So we think we're giving patients information by giving them risk information like this, but in fact there's a lot more to unpack there, and there's a lot to understand about how people are interpreting that kind of information. And it turns out that people's perceptions of risk and the subsequent decision that they make on the basis of those risk perceptions depend on the framing of the risk, context and contrast, their numerical competency, their forecast for how much they will like or hate future physical states. And these are all the things I'm going to talk about today, kind of unpacking the talk. Just as the basics for when we're talking about risk perception, we talk about risk in common vernacular in a number of different ways. So we say, you know, the risk of this surgery is bleeding. That's actually a harm. It's not in fact a risk. Or we say the risk of a heart attack is 10%. That's a probability. But when we talk about risk, the formal definition of risk is it's a combination of both the probability and the severity of an event. So a very low risk thing would be something that is low in probability and low in severity. Something that's high risk is high in probability and high in severity. So I just want to make sure that we're clear on that. And now I'm going to confuse you a little bit more, because in decision psychology, we actually use the word risk in a slightly different way. So we use the words risky choice or risk-seeking behavior. And the way that is usually understood is choosing an outcome that is less certain. Let me give you an example of that. So I want you to consider the following two options, all right? Option A, I'll give you $10 for sure. Option B, there's a 20% chance that you will lose $10, and there's an 80% chance that you will win $20. So how many people in the room would choose option A? Okay, how many people would choose option B? Okay, so it's about 50-50 split for those of you who are on Zoom. And some people seem pretty not sure, or maybe they just didn't want to raise their hand very high. So we can in fact calculate which bet is objectively better in terms of expected value. So the first option is, the first option has an expected value of $10. The second has an expected value of $14 as calculated by your win or loss and the probability of that win or loss. So option B is actually the better bet. But why would somebody choose option A? Certainty, right, exactly. In this case, those of you who chose option B would be considered to be making a more risky choice because you're choosing the less certain outcome. Okay, so you're being risk-seeking. If you choose option A, in spite of the fact that it has less value, you are being risk averse. You are choosing the less risky option. So now I'm going to segue into one of the most famous psychological scenarios of all time. And I wonder how many of you are actually familiar with this. Okay, how many of you are familiar with this Asian disease problem? Okay, like just some. All right. So imagine for me that your country is preparing for an outbreak of a disease and it's expected to kill 600 people. Which of the following two drug treatments would you prefer? Drug A, 200 lives are going to be saved for sure. Drug B, there's a 1/3 chance that all 600 lives are saved and a 2/3 chance that no one is saved. Okay, how many people would choose drug A? Raise your hand high so I can actually see. Okay, how many people would choose drug B? How many people aren't sure? Most people are not sure. Okay. All right, well, so we had a 50-50 split on people choosing drug A and B, and most people are not sure. Thanks, guys. You're not playing along very well. Okay, so I'm going to now segue to another question that is very similar, but it's different. So imagine that your country is preparing for an outbreak. 600 people, it's expected to kill 600 people. Which of the following two drug treatments do you prefer? Drug A, 400 people will die for sure. Drug B, there's a 1/3 chance that nobody dies and a 2/3 chance that all the people will die. How many people choose drug A? Nobody is willing to play my game anymore. Anybody want to choose A? Okay. Anyone want to choose B? Most people are choosing B. Okay, now those of you who, whenever I show this to people, there's people whisper, they go, they're the same, they're the same. It's because they're the same. They're exactly the same. So the two questions are mathematically equivalent. The first one is presented in a gain frame, as in lives saved. The second one is presented in a loss frame, as in lives lost. So for example, drug A, you have 200 lives that will be saved, but we're talking about 600 people, so 400 people are going to die. For drug A in the loss frame, you say 400 people are going to die, but that also means that 200 people are going to be saved. What you see many, many people do when they're willing to play this game, or we force them to, is they choose drug A for the gain frame, but they choose drug B for the loss frame. So they switch their preferences. And the reason why is because people love a guaranteed gain. And they hate to gamble on that. They want to get that gain for sure. But they hate a guaranteed loss. So when you frame it in terms of losses, they go for the more risky or the gamble-y choice. Kahneman and Tversky famously concluded from the scenario, and others, that people are risk-seeking when it comes to losses and risk-averse when it comes to gains. And on the basis of this conclusion, they proposed something called prospect theory, which I'm displaying with this graph. And Daniel Kahneman ultimately won the Nobel Prize in economics for his contribution with prospect theory. And this formed the basis of what we now know as behavioral economics. So behavioral economics is, and started with, this kind of basic psychology. So here's where I wish I had a pointer, but I'll try to describe this without a pointer. What we have here is a function that includes gains on the right-hand side and losses on the left-hand side, and then value on the vertical axis. So higher on the vertical axis is greater value, right? And you would expect that gains are going to give you positive value and losses are going to give you negative value. And that makes a whole lot of sense. But Kahneman and Tversky's famous insight is that the first thing you'll notice is that these lines, they're curved. And the second thing you'll notice is that there's a much steeper drop-off for losses as opposed to gains. And the steep drop-off for losses indicates that people are much more sensitive to losses than they are to equivalent gains. So losing $100 hurts a lot, and it hurts much more than a gain of $100 yields pleasure, as shown on that graph. So that's the difference in slope that you see there. The curve of the line indicates that changes from our midpoint have a much bigger, small changes from our midpoint have a much bigger psychological impact than changes beyond that midpoint. So for example, winning $100 gives you a whole lot of psychological value, but then winning an additional $100 doesn't give you the double the value, right? So for example, going from 0 to 100 is, wow, I just won $100, that's really great. Going from $900 to $1,000, it doesn't feel so great. You don't get as much increase in pleasure. And I want to just point out really briefly why this was so important. Because prior to Kahneman and Tversky, the major assumption was that this is going to be a linear function, that all gains are considered equally positive, all losses are considered equally negative. So for example, this is how good, according to the theory prior to prospect theory, it would feel this good to win $100, and it would feel this bad to lose $100, so it's equivalent. And then if you were to win $200, it feels twice as good as winning $100. And that's not true at all. It's just not a good description of how people psychologically respond to gains and losses. Okay. All right, so I'm straying far from shared decision making. I understand that. I'm going to bring it back in a minute. So the big takeaways, in case I lost you with the graph, is that people have more extreme reactions to losses and gains, and that people react more extremely to changes in gain and loss that are closer to that reference point than changes that are further away from the reference point. And this is just a feature of human psychology. So here are the lessons for shared decision making. The first big lesson is that the way that we present risk is affected by how we frame it. And the thing about risk and probabilities is that we can provide either a negative or positive frame. So earlier I asked you, what do you make of a 25% chance of heart attack? Well, you could also frame that in the opposite way. What about a 75% chance of avoiding a heart attack? The 25% chance of the negative thing is much more psychologically impactful than the 75% chance of avoiding that bad thing. Okay? So when you frame these probabilities, these risks in terms of losses versus gains, it can have very important differences in psychological impact. And so in order to avoid bias, and this is just a basic insight, we need to use both frames whenever we can. We need to frame the chance of a heart attack as 25% and the chance of not having a heart attack as 75%. The other lesson for shared decision making is that when people go from something not happening to a small probability of that bad thing happening, like death, it has a huge impact on them. But if you have an equivalent increase in probability at other points in the probability, like for example, going from 16% chance of death to 20% chance of death, people basically equate those numbers. It just doesn't have the same psychological impact. So in order to demonstrate the latter point, I want to tell you about one of my most favorite, a medical decision-making scenario. So now I'm going to have you imagine that you have colon cancer and that you have a choice between two surgeries. Surgery A, there's an 80% chance that you're going to survive and a 20% chance that you will die. Surgery B, your other option, because we're sharing in this decision, you get to choose. Surgery B, there's an 80% chance of survival, a lower 16% chance of death, but there's a 4% chance that you're going to survive, but with a colostomy. So your excrement will be collected in a bag on your abdomen. Okay, so how many people here, again, please play along, how many people would choose surgery A? How many people would choose surgery B? And why are you all choosing surgery B? Because death is less. Yeah, you guys are not representative, by the way. You're probably very numerate and also in a medical field of one kind or another, which is causing you to probably appropriately evaluate the situation. Participants are posed this question, they make a choice, and then they get a follow-up question, which is, would you prefer to be dead or have a colostomy? And here's what about a third of people do. They choose surgery A, and then they say, oh, of course I'd rather have a colostomy than be dead. But of course, this is an inconsistent choice, because if you think about surgery A versus B, the only difference is that 4% chance of a colostomy versus the 4% chance of being dead. This is a trade-off between death and colostomy. That's what this choice is, and what you all seem to understand. What many, many people do is they make this inconsistent choice. So why do they make the inconsistent choice? The first reason is because they think they have a negative affective reaction to the prospect of a colostomy. They say, ooh, that sounds really bad. I don't want to do that. But then when they're comparing so then they look to surgery A and they say, oh, well, 20% chance of death and a 16% chance of death is basically the same. So they equate those two probabilities. Again, a 16% chance of death and a 20% chance of death are psychologically more equivalent than a 0% chance of colostomy and a 4% chance of colostomy. With colostomy, you went from not possible to possible. With death, you went from might happen to slightly more likely to happen, but probably not really. Okay. So all of this should be causing you to wonder how it is that people make risk judgments. And if you're following along, you're probably starting to realize that risk judgments are primarily about feelings. We don't just think about risk, not purely cognitive. The way that we derive meaning from risk is we feel it. And in fact, if we didn't have feelings, I think it'd be really hard to think about risk for ourselves. So now another imagining. I realize now that I'm having you guys doing a lot of imagining. But now I want you to imagine that you are told that among people like you, 20% of them will develop breast cancer if you're a woman, prostate cancer if you're a man, in their lifetime. 20% of people like you will develop this cancer in their lifetime. How does that feel to you personally? How does that feel? And then, because we just learned about prospect theory, we're going to also provide the alternative frame that 80% will not have this cancer in their lifetime. That probably immediately feels a little bit better to you. It does to me. Even knowing all of this, it feels better to me. But in any case, how does it feel? Does it feel good or bad, scary? Well, it turns out that how we feel about risk depends not only how it is framed, but it also depends on our expectations. It turns out that when you ask people, what's your risk of breast cancer? If you ask women this, and if you ask men, what's your risk of prostate cancer? They say crazy things like, my risk is 60, 70%. So many women think that their risk of breast cancer is greater than 50%, which is wrong for the vast majority of people, by the way. 20% feels pretty low by comparison. And so the risk feeling that you might derive from that is, oh, wow, my risk is really low. Right? So you're interpreting that risk number in light of your expectations. And in fact, this work by Angie Fagerlund that I'm citing at the bottom indicated that when you ask women what they think their risk is, they say this really high number, and then you give them this low number and they feel relief, they feel positive, they feel like the risk is pretty low. If you don't elicit that idea about their pre-existing belief about the risk, then the 20% number doesn't have that contrast and they don't feel as relieved by it. How you feel about that 20% number is going to also depend on social comparisons. So it turns out that for both breast and prostate cancer, the average lifetime risk is about 13%. About 13%. Well, in light of that number, 20% seems high. And so if you're told what the average risk is, you might develop a risk feeling that, oh, my risk is high. Ooh, it's above average. And in fact, this other paper that I'm citing, also by Angie Fagerlund and colleagues, showed that when you tell women that their breast cancer risk is above average, they interpret their risk as being indicative of a need for taking some action against it, and they're much more willing to take a breast cancer risk-reducing drug like tamoxifen or raloxifene. Women not told that their risk is above average don't have that same reaction, even though they're responding to the same number. Okay, so all of this, lots of other research that I'm not talking about, led to some pretty serious thinking among experts about how to communicate risk to patients in a shared decision-making space and with patient decision aids. And the reason why serious thinking is required is because this kind of research makes it abundantly apparent that the way that we communicate about risk to people has implications for how they understand it and then what they subsequently do. And now if I wanted to, if I wanted to get a woman to take a mammogram, or if I wanted to get a woman to get a mammogram, I would give her a loss frame, I'd tell her her risk is above average and say, oh, it's higher than expectation. Your risk is higher than expectations too. So we kind of know how to use these techniques to persuade. But in a shared decision-making context, persuasion is not what we're trying to do. We're trying to communicate risk information in a way that's not biasing and that's as neutral as possible. And so the question is then how to do that. Another thing we want people to be able to do is to derive really critical meaning from the information that we're giving them. And one of the people in this world who has done some fabulous research about how to create meaning in both risk numbers and the results of medical tests is Brian Zygmunt Fisher, who, just full disclosure, is one of my collaborators. So I'm just going to tell you about a brief study that he did. This is a blood test result, so platelet count. And you can see that your result, according to this table, is 135. And if you're just given that number, you'd be like, what is that? I have no idea. That's terrible information. 135 is totally meaningless to me. But you're also given the standard range, so you know that you're a little bit below average, or below standard, I should say. You're not necessarily told whether that's good or bad, right? You're not told how deviant that is. Is that something you should be worried about? Is that something that's not too worrisome? So it's really necessary when we're giving people information like this to give them a lot more context for understanding, and the way that we present that depends on what meaning we want them to derive from the information that we're presenting to them. What's the most important takeaway that we want patients to get? And these researchers, they tested a couple of different ways of presenting the information. So the first graph that you see in the middle there, that bar, it has a number of improvements over the table. First of all, it's showing you a big range, and it's showing you that the lowest possible value here is 0, and the highest possible value, although it goes on, it has an arrow going on, is 500. It shows you the standard range, but it also has this green color that kind of fades away at the edge of the standard range. And what that communicates to patients is, yeah, these are our cutoffs, but there's some ambiguity. I mean, they're kind of arbitrary cutoffs, right? Like, it's not like you die when you get to, 149. So we need to convey to people that these are arbitrary cutoffs, or at least one thing you might want to convey to people is that these are arbitrary cutoffs that, now you can see that your platelet count is not in the standard range, but it's still in green. It's kind of trending towards something that's gray. You don't exactly know what gray is. It's not labeled. So anyways, that's a nice segue to the bottom figure, where you are given hard cutoffs, right? We're not given this fuzzy, kind of conveying ambiguity or uncertainty around the cutoffs. But we're given a very clear label for how we should interpret this number. It's borderline low. It's not low. It's not very low, but it's borderline low. And we're using colors also to convey the amount of concern that a person might have about this number. It's not red, it's not even orange, but it's not green, it's yellow. So maybe this is something that you want to follow up on, maybe, not ignore, but also not maybe act on right away. So we can have a lot of control over the meaning that people derive from information by just using displays like this. And this is something that we really need to keep in mind when we're engaging in shared decision making, because people just don't derive much meaning from, your result is 135 and the standard range is 150 to 400. It just doesn't have a lot of meaning. Oh, and people will decide what meaning it has too, depending on their proclivities. And that's probably even worse than influencing them a little bit to pay attention to stuff we want them to pay attention to. Okay. So as a result of all these concerns, the International Patient Decision Aid Standards Group, that's IPDIS, has created a couple of different papers that have prescriptions for how we should be communicating risk and results to patients. The first thing on the list is gain and loss framing. That's pretty obvious. That was one of the first insights. Another thing is you need to identify a reference class. So you never want to say your chance of having a heart attack is 10%. Like 10% of who? Of all the people in the world? A better way is to say, among people like you, that's the reference class, 10% will have a heart attack. Much easier to understand, less ambiguous. Even better would be to say, among people like you who have your risk factors of XYZ, 10% will have a heart attack. Generally, people will say you need to present numbers. I agree with that. Even to people who are less numerate, and I'll address that on the next slide. One of my beating drums little pet peeves is you absolutely must use absolute risk, not relative risk. Relative risk is misleading, can be very persuasive, but it's not but people don't know how to interpret it. Providing context and evaluative labels to increase meaningfulness of the information is very important, and to be very thoughtful about what meaning you want people to derive. And then also use graphs, like icon arrays. These are just some, I actually had like a huge list of things that IPDIS recommends, and I deleted many of them for the sake of time. So this is a lot of numerical information that we are communicating to people. We know from national surveys and educational results that people in the United States are disturbingly low numerate. Many of them are, at least. And so what do we do when we're communicating to a person who is low in numeracy, meaning they don't work very well with numbers, and maybe they're low in literacy? And I just have a couple of things to say about this, and there's so much literature on this, it was really just hard for me to think about what to show you. So instead, I'm going to give you a couple of takeaways. And I think these are important. I want to acknowledge that communicating to people who are low in literacy and low in numeracy can be pretty challenging relative to people who have a better grasp of numbers and language and literacy. But when we present things in multiple formats, so we present something in words with a graph and with numbers, that can actually help a lot. And the reason why is that some people are better with words, some people are better with graphs, and some people are better with numbers. So you kind of hit them with all three, and you get the maximum probability that you're going to help people to understand. Plus, some people are low in numeracy, but they're actually pretty high in graph literacy, which is a different thing. Slightly, I mean, they're related, obviously, but it's slightly different. So if you're communicating to somebody with low numeracy, it might help quite a bit to show them a graph. I also want to point out that communicating risk can be challenging for people who are high in numeracy. The biases that I told you about earlier are prevalent among people with high numeracy as well as low numeracy. So just because you're good at numbers doesn't mean you're immune. And just because you're good at numbers doesn't mean this stuff is easy to understand. So we need to help people. And so I guess the key point where I'm leading with this, this brief foray into talking about numeracy and literacy, is that there's often kind of this impulse to say, oh, well, this person wouldn't understand the numbers, so I'm just not going to show the numbers to them. And that's wrong, because people can understand numbers, even people who are low in numeracy, and we can develop tools that help people to understand. And so you don't want to give people with low numeracy or low literacy different considerations for shared decision making just because they lack those skills. Instead, we want to design tools that help everyone understand better. Okay. So the next thing I'm going to talk about are biases that are related to affect, and affect is a very simple thing. Psychologists use the word affect to mean just your positive or negative feelings about something. So you might have like positive affect towards Subarus and negative affect towards smoking, or anything. One of the more important biases or errors that people make related to affect is a forecasting error. So an affective forecasting error, affect is how good or bad you feel, forecasting is how good or bad you feel in the future. And the error that people make is they're not very good at knowing how they're going to feel in the future. So some of the early research on affective forecasting errors ask people, how good would you feel and for how long if you won a $10 million lottery? Now, most people are correct in thinking it would make them very happy. That's kind of obvious, but people make some systematic errors when they're making these judgments. People believe that their happiness will be more extreme and will last longer than what is actually the case when you survey people who won the lottery. So people tend to have this increase in happiness, and then they pretty quickly go down back to whatever level of happiness they were at before. Because a person who's unhappy is going to be unhappy no matter what. That's kind of the idea. A person who's happy is going to be happy even if they don't win the lottery. So medical decisions, as you're almost certainly aware, require people to think about how they're going to feel given different health states. So I have, a man might say, I have early stage prostate cancer. How bad would I feel if I was impotent and incontinent as a result of receiving surgery? Versus watchful waiting. How bad would I feel if I didn't have surgery and I left this cancer in my body and I just did watchful waiting and I had to go to the doctor every 6 months to get this checked? Some of the research, medical decision-making research in affective forecasting has looked at how people feel with an ostomy. So they asked people, how bad would you feel and how long if you had to live with an ostomy? And we're getting back to colostomy, and this is because of Peter Ubel, who's obsessed over ostomies and colostomies for a while. And he led this research. So, just like winning the lottery, only reverse because this is bad, whereas the lottery is good, people think they would be more unhappy and they'd be unhappy longer than people who actually receive an ostomy. And so this can be bad for people who maybe would benefit from an ostomy, like people with chronic ulcerative colitis, who widely report better outcomes and better quality of life after receiving an ostomy, but they don't want to do it because they think an ostomy is going to be so bad. So one question is, how can we improve people's affective forecasts as a part of shared decision making? And one really important answer that quickly came to the fore is experience narratives. So give people stories about people who had different health outcomes. Tell people to give people a better idea of what it's really like. So in one study by Andrea Engot and Peter Ubel and colleagues, they had participants watch a video of a person changing an ostomy bag. And what they found is that after people watched the video, they estimated that quality of life with an ostomy bag would be much better than prior to having watched the video, because now they understand what it's really like. Okay, so the next affect-related bias that I want to teach you about today is the affect heuristic. So far what I've told you about are the way in which our perception of risks and benefits can dictate how we feel about something. And I told you about all these things that feed into how we interpret the risks and benefits, like gain-loss framing, contrasts, and forecasting errors, and all that stuff. Well, it's also the case that the reverse can happen, where how somebody feels about something can feed into their perceptions of the risks and benefits. And this is called the affect heuristic. So, for example, a person might think implicitly, usually this doesn't happen explicitly in a person's mind, but for example, a person might think, well, I feel really negatively or bad about taking medications. I don't want to take them. So statins are probably low in benefit and high in risk. So their estimation of how those benefits and risks, even if they're given the numbers, will change depending on just what their preconceived evaluation of the thing is. I don't like it, so it's probably high in risk and low in benefit. Or I feel really great about cancer screening, really positive affect towards cancer screening, so high benefit, low risk, regardless of the numbers. So that can shape how people make their decisions. And they're coming to the table with these feelings. So then one question is, well, where do these feelings come from that they're coming to the table with? And of course, the answer to that question is pretty huge, but you can narrow it down. Media exposure is a huge one, so people can form positive evaluations. There's all kinds of things that they hear about in the media, like the Angelina Jolie effect, which she talked about, getting tested for genetic mutation for breast cancer and then having surgery as a result. Prior health messages can influence people. So for example, women have been told forever that breast cancer screening, you absolutely must do it starting at 40. Well, that creates like a lot of positive affect about breast cancer screening, so that then they may, when they're presented with the risks and the benefits, they may interpret the risks as being more positive or the benefits as being better and the risks as being worse, which can create problems when, you know, the American Cancer Society is recommending shared decision making, and then, you know, women react to this information on the basis of prior health messages, which may no longer apply. The features of the intervention themselves can dictate how people feel about them and then have downstream consequences for how we evaluate the risks and the benefits. So colonoscopy is a big one. People, when they have any knowledge about it whatsoever, they think, oh, that seems uncomfortable and embarrassing. I don't like that. And so then that may cause them to underestimate the benefits and overestimate the risks. And then one of my favorite things to talk about, if you talk to me for more than 10 minutes, I'll probably mention medical maximizing and minimizing orientation. So maximizers are people who want to go out and they will maximize their utilization of care. They like to go out and seek care. So they're going to feel very positively about active interventions and feel more negatively about messages to do less. And that can also impact their perceptions of the risks and benefits. I was going to give you an example of that, but I had to take it out for the interest of time. Whereas a minimizer is going to be more receptive to messages to do less, because there are people who want to do less unless they feel like they absolutely have to get medical care. So these pre-existing feelings towards medical care can potentially disrupt the shared decision-making process insofar as it can shape people's receptivity to the information that they receive And that can happen in terms of their affective feelings and their perceptions of the risks and benefits, but it can also influence their acceptance of the information in the first place. And so the last thing that I wanted to talk about is motivated reasoning. So when people have strong pre-existing attitudes and beliefs about something, that can result in what we call motivated reasoning. And motivated reasoning is simply all the different kinds of reasoning strategies that people can engage in that are all geared towards maintaining a pre-existing belief. So most of the time people are accuracy motivated in their reasoning. They want to get it right. But when they have a pre-existing belief that is really strong, they have a hard time accepting information that may contrast with that pre-existing belief. So they engage in all these strategies to try to maintain. And these strategies can include ignoring conflicting information, discounting that information, saying things like it's not really true for me, or just outright disbelieving it. So this is a case in which a person might have pre-existing feelings, pre-existing beliefs about what they want to do, and that can influence not just their perceptions of the risks and benefits, but whether they're willing to accept the information about the risks and benefits in the first place. So for example, a person might use reasoning strategies like, you know, I would be more or less, as the case may be, likely to benefit from this than the average person. You're telling me I'm average, I'm not really average, I'm more likely to benefit. Or there has to be more benefit to this intervention than what you're telling me. This seems like an underestimate. Or, you know, these harms that you're telling me about, because we are doing balanced shared decision making here, these harms are really overblown. I don't think they're all that important. Or these harms wouldn't happen to me. I'm less likely for XYZ reasons. The communicator seems untrustworthy. This isn't my doctor. This is some specialist. Or this is a decision aid online. I don't think I really trust this. These people have a motivation to convince me to not do this or to do this, and so I don't really trust this information. Or, I think this is the most problematic, I just don't believe it. Some people will just say, I just don't believe it. I just don't believe what you're telling me. And because of people's propensity for disbelief in certain kinds of evidence that go against their pre-existing beliefs, I think that this bias, motivated reasoning, is one of the more problematic ones that shared decision-making potentially has to face in certain contexts. The reason why I think it's one of the more problematic is because it can cause people to conclude that this evidence that they are receiving either doesn't apply to them or it's just untrue. And that's really problematic, because if you have people who are doing that, then they're going to make decisions that are not achieving the goal of shared decision making. Their decisions are not going to be based on evidence. The patient might be informed. You did inform them, you did your due diligence, but the decision that they make is not informed. And that is potentially problematic. These other biases, like the affect heuristic, is something that it just kind of is. If you feel positively towards something, you think that the benefits are high and the risks are low, and it's a perception, and it's a bias, sure, but it's not necessarily wrong per se. Motivated reasoning, and particularly when it leads to expressed disbelief, can lead to decisions that are wrong insofar as they're not accounting for all the information. Okay. All right. Now I'm just going to summarize what I've told you, and then you guys can ask me questions. So I've gone through all these different biases in risk perception and decision making. I told you about prospect theory, context and contrast effects in people's evaluation of risk numbers, taught you about the affect heuristic, affective forecasting, and finally motivated reasoning. As a result, and we also talked about numeracy, that's not on this list. All of these phenomena can be used to create some recommendations from psychology to shared decision making. And I'm sure you can think of more than what I'm going to tell you. Again, just rehashing, use gain and loss framing whenever you're talking about a risk number. Because if you use gain framing or loss framing, it's going to bias people. And you don't want to do that. So that's the lesson from prospect theory, one of them. Present risk and benefits in a way that helps people to derive meaning from the information. The information does not have meaning just alone. You have to help people to understand. And that requires a judgment call on the part of the expert and the developer of the decision aid. There will be judgment calls that need to be made And it is truly impossible to present information that is not in any way biasing. However you present the information is going to bias people in one direction or another, so you want to make sure that however you're presenting it is the way that patients appreciate and want, and ways that experts feel is the most important in terms of driving takeaways. Help people, particularly using experience narratives, make accurate forecasts about how they might react to different health states. Because people are bad at this. They're just really pretty bad. And so you need to help people. And we can help people with narratives. I'm sure there are other ways as well that we have not discovered yet. Acknowledge that people's feelings are going to create their perceptions of risks and benefits, and that this is just something that happens. You could call it a bias when it really leads people astray, but when it's not super leading people astray into, uncharted territory where they're wanting to do something that the physician would not recommend, you just have to acknowledge that this phenomena exists. And then I think it's important to address motivated reasoning, but particularly when it's causing people to question or disbelieve the evidence that you are trying to convey. Okay, and that's all. And I did that in 50 minutes. I'm so proud. Thanks. Great. Yeah. Oh, yeah. Yeah. Mm-hmm. Yeah. An affect heuristic. Yeah. Yeah. Mm-hmm. Yeah. Mm. Yeah. Who's who? Right. Mm-hmm. Right. Well, and with vaccines, that's particularly important because some people, like you said, you're never going to push towards, you're never going to get them to yeah, right. Don't waste time on them. They're just going to get angry at you, and they're going to maybe drop you as a physician if they really feel like this is becoming a hostile relationship. But then, and then you have people who probably say, okay, what's the next vaccine? But then it's people in the middle. How do you talk to them? And then, yeah, I guess you're talking about triaging those people, so you know who to invest all that time in. Yeah, what would work? Yeah. Right. Yeah. I feel like we could be better at doing that. I mean, goes beyond shared decision making, and like you said, into situations where we have this normative thing that we want people to be doing, and they're not doing it. So then we're in a persuasion context. In a shared decision making context, it's harder to really know. I mean, you might have to spend, or a person might want to spend, a week thinking about whether or not to get PSA screening, and you're certainly not going to sit around and wait for them. And that person might really benefit if there is a take-home decision aid that they could just kind of peruse through while they're making this decision. You say, I can see this is hard for you. Here's this. Take it home, look at it. We can make this decision later, right? But yeah, for these non-preference sensitive decisions, it does seem like if you could just streamline people into the intervention that would work best for them, that could be a really great use of energy, research energy, really, is figuring out how to do that. I don't have a great answer for your question. I think it's a good idea. Okay, maybe we should do that. Yeah. Yeah. No. Person might not even be conscious. Good question. Yeah. Um, yeah, sure. So the question is there some agreed upon standard for which, or situation in which shared decision making is accepted and desirable? You know, where are the limitations of that? Like, what kind of situation do we expect shared decision making to happen in? And I would say that consensus on whether shared decision making is appropriate seems to be emergent. So for PSA screening, it was not a shared decision for a long time. You just did it without even asking the patient sometimes. So it wasn't even an informed decision. You just told them, oh, your PSA looks great. I just did it with a recent blood draw. And then as the evidence became stronger and stronger that if there was a benefit, it was very small and not necessarily outweighed by the harms of PSA testing. Then I think there was more disagreement about what to do. And when there is not good medical agreement among experts about what to do, people look to the patient and say, well, what would you want to do? Given this sort of complex trade-off between risks and benefits, because you can imagine that somebody would see this and say, I definitely want to get this test. I'm willing to, risk the harms. Another person might say, yeah, no, those benefits aren't enough for me. I don't want to do it. And the harms seem pretty significant for me. And so that's where shared decision-making emerges. But I mean, I've had conversations with people about situations that I think are very ripe for shared decision-making, and they say, no, I don't think so. So for example, I think there's disagreement in cases where the evidence is not strong in favor of an intervention. PCI for stable angina is one of those cases where there is emergent evidence that maybe it doesn't save lives, doesn't prevent heart attacks. Does that mean that we should be telling people that we have a little bit of evidence and it's not looking good? Or should we be just going ahead and using, clinical expertise and knowledge to be making those decisions for patients? And so there's a lot to unpack in your question. Mm-hmm. Right. Oh, right. And yeah, and yes. Uh-huh. And there are some people who argue that every single medical decision should be a shared decision. Yeah, except for the ones where the patient's unconscious. Right. So that, they're being wheeled into the, emergency department and they're not conscious and they have a gunshot wound. That's not shared decision-making time. But for many of the decisions that you see in other kinds of practices, some people argue that every single one should be shared. So very much a matter of opinion. And when there is consensus is oftentimes because people have been talking about it for a long time and it has emerged from those conversations. Yeah. Questions? Yeah. Okay. So can you give me an example to work with? Okay. Oh, so you're thinking that whichever frame they get first in that kind of situation is going to be the one that they latch onto. You may very well be correct about that. So when people are in, I think Gretchen Chapman is actually probably going to talk about this kind of thing a lot more. When people experience a really intense emotions that can put them in a state of cognitive load, which is psychology speak for just not only being able to pay attention to one or two things because they have so much on their mind that's taking up their working memory. And in that case, the second frame that they hear may simply not be heard, so it doesn't become encoded in the first place, getting back to the encoding and retrieval issue that I very briefly mentioned. So it doesn't get encoded, or it is insufficiently weighted, so it's just not weighed equally. And I don't even necessarily think that, although I'd have to review the evidence, that it is necessary for a person to be under cognitive load or emotional stress in order for that to happen. I think that sometimes people latch onto the first frame that they get. Yeah. So there's no such thing as unbiased, right? Yeah, right. Yeah, it's very, very difficult to present information in a way that is completely neutral. And in fact, I think there's a very strong argument to be made that there's no such thing as neutrality, because this is all subjective. And so our job in shared decision making is to present this in a way that we think is sort of going to give people the most accurate representation, the most unbiased representation of the situation that they can possibly get. Yeah. Yeah, I mean, there's so much there. I think that you definitely don't want to make assumptions about how much time a person to spend with a person, right? But some people come to decisions very quickly. Like for some people, they just come to the table and they know. And it's because of their values and it's because of their perspective, and they just know what they want to do. Right? Like imagine I was a medical maximizer. I really like to take medications, doing things for my health that I feel are proactive. You offer me medication, I say, done. And you say, wait, there are risks and side effects. And I go, no, it's cool, done. You told me there's a benefit and there's a reason for offering it to me. Great. Right? So. Yeah. Well, let's run with this example for just a little bit longer. I know we're out of time. Okay.
So, let's talk about this example.
Yeah.
For
Okay.
5 more minutes.
Okay. We can finish off the example because I think there's some interesting stuff there. Yeah.
Thank you so much, everybody, for coming.
Yeah.